MedBix Webcast is a new kind of healthcare media channel to break the silo mentality and foster interdisciplinary thinking. Our mission is to fill that gap and to create a curiosity through different lenses, tapping the passion that guided the historical figures in medicine and bringing present-day groundbreaking research to the front lines. We interview physicians and leaders in the industry about present-day healthcare challenges on our live programming. Welcome to the MedBix Webcast. This is Ramana Annamaraju. I'm not Albert Einstein, but I'm pretty good. It's such a joke. I have actually better smart people are coming up on right now on my broadcast. And then, we're going to talk about something about disaster medicine. Very interesting. That is a branch itself. Very complex subject. I saw that what are the things involved in the disaster medicine. It is a very intriguing to know a lot of things. And then also billing. When during the disaster times, the doctors, the providers, the billing is a very interesting itself. That itself is a separate field. So we're going to learn from our guest, Dr. Ramirez is going to join us. He is a disaster medicine doctor, and he is a well-accomplished disaster medicine physician, and then we'll ask him a lot of questions about what inspired him to be joining in that kind of thing. He was working for the federal government for a while, and then after that, he is a disabled physician himself, and he can tell you his story. But also, I'm going to be joined by my co-host. Her name is, it's very interesting. I need a co-host because she's a better looking and better accent. So Sheila is going to join with us. Sheila Dawlatishi. I think that's how I said it right. But let me bring Dr. Ramirez on the stand. Dr. Ramirez, welcome to the MedBix Webcast.
Good evening, Ramana. Good evening. It is a pleasure to be here. How are you this evening?
Good, excellent. Tell me about, can you give us something about background? What is your background actually? How did you end up in this kind of a situation, disaster side? It's a way, physicians don't, they don't dream about going to the disaster medicine. you took it out that path drove you. So give us a little bit of a path towards that direction.
Well, a few of us do actually dream of doing expeditionary or austere environment or disaster medicine. I started out as a government contractor even before medical school, went on to medical school, and then had a 25-year career in clinical emergency medicine, mostly fixing broken rural emergency departments. Simultaneous to that, I was one of the responders who was first out the door when anything blew up, blew in, blew down, or blew over in the continental United States. We were generally out the door in 2 hours, in the air within that 2 hours, and on the ground, hopefully within 4 hours of being in the air, and providing services in an ideal situation, 12 hours. And there are over 5,000 other healthcare providers around the country who are signed up to be deployable in that fashion. All of them saw, of course, action during the pandemic.
Absolutely, great service. That is. So, what kind of things are involved? What kind of medicines? What kind of a specialists are involved in the disaster medicine?
Well, disaster medicine is really the provision of healthcare during and after a disaster, but it also includes the full disaster life cycle. So we deal with preparedness and education, mitigation of hazards, as well as the actual on-the-ground response, and then the recovery of healthcare afterwards. What a lot of people forget is that when your community evacuates in advance of a hurricane or wildfires, your doctors and nurses, your paramedics and your PAs, your nurse practitioners, all go or should all go as well, except those essential personnel to maintain healthcare until the community has evacuated. That creates a vacuum. There's a lack of specialists. There's a lack of general healthcare until those people can return, until it's safe for them to return. In some cases, until they have a place to return to. In disaster medicine, We come in that void until the local people can come back, and we provide health care for those who weren't able to evacuate or those who are responding to the disaster.
Can you give the logistics of the what state, federal, and county? How does that logistics of the disaster medicine work? So somebody has to make a call. State has to invite them. What are the logistical procedures for the to declare as a disaster medicine disaster area?
Well, all disasters are local, so everything starts at the local level. Local, municipal, or state officials determine that there will be a situation that will exceed the local resources available to respond. So when needs exceed resources, when you know that's going to happen in advance, then the state or local emergency management contacts the state emergency operations office or the governor of the state or territory to request a disaster declaration. Now, that kicks in at the state level. Once there's a state declaration or a state determination of a disaster or impending disaster, then under the Stafford Act, which is federal law, a request is made either of FEMA or of the Emergency Response Center in Washington, D.C., or directly to the executive branch, the White House, or the president, to then declare a federal disaster. Once there's a federal disaster declared, then federal assets come available. When the state disaster is declared, the state assets become available to the local. But the reality is that a disaster happens whether you declare one or not. If you have a school shooting, there's no state or national disaster declaration, but there is certainly still a local disaster that requires local resources and mobilization, coordination. The key is less about the process of declaring that disaster than it is the process of preparing for it well before a disaster occurs. And that's what we refer to as disaster readiness.
So in disaster medicine, you have infectious diseases, you have epidemiology, public health, and all those. What else? Mental health. What are the other areas involved in this whole process?
Well, all specialties are involved in disaster medicine because all specialties are involved in the provision of healthcare. So when you're replacing healthcare you have to replace the emergency medicine and not just supplement the public health and epidemiology. You also have to make certain that you have surgery, that you have trauma, that you have obstetrics. There was Hurricane Katrina in the Louis Armstrong International Airport. The first birth after the hurricane in the evacuation area was a C-section performed in Concourse C. Wow. Fortunately, Tulane and LSU were able to provide gynecologists to perform the surgery. If not, it would have been us ER doctors doing the C-section.
It's incredible.
It's incredible. Yeah. So how do you, so you have to work as a disaster medicine physician. You have to work with the first responders. That's one of the coordination and logistics are very important in this process. Is it that, do you think that is a logistical process, first responders participation of?
There are first responders, of course, and first responders in a disaster becomes a much broader concept. It's not just EMS and law enforcement anymore. Now part of your first response are emergency management. It's the line workers who are going to restore the power so that your hospital can come off of generator. It may be the water department ensuring that you have potable water for the 5,000 evacuees that you have. Or it may be truckers who are bringing in water and supplies. There are communications experts, because the first thing, we all live with our cell phones. The first thing people want to do is they want to get on Facebook and mark themselves safe, or call their family, or worse, they've been separated from their family. So you have to have communications experts. In fact, in the federal disaster framework, the National Response Framework, we have 18 emergency support functions, only 2 of which deal with healthcare directly.
Interesting.
And the other 16 deal with all the other components of the operation of normal society and normal communities. But we have to support those during a disaster because the local area, the place where the disaster has occurred, has been overwhelmed.
Mhm.
People don't realize that communication plays such a vital part in the disaster area, disaster times. So that is the first and foremost, and before even the healthcare come in the picture, you need a communication is the first and foremost one, right, Dr. Ramirez?
Well, that's the reason that these are 18 parallel areas. And in
That's
some
it.
states is as many as 24 parallel areas. Each one trained and equipped so that they can respond independent of the other 24. And that allows healthcare to arrive as soon as healthcare can. And yeah, in a case of teams that I've been on, sometimes as early as 2 days before the landfall of a hurricane, sometimes within 6 hours of a major event. But you obviously want to have the linesmen there as soon after the hurricane as possible to get the power back on. And yet, and the community, the all 18, all 24 in the state of Florida and many other states, you want them to all arrive at their earliest safe ability to arrive with resources, because it's also useless if people arrive and they don't bring anything with them or their equipment hasn't arrived ahead of them.
Interesting. Dr. Ramirez, what is now the biggest concept in the disaster medicine? As in other third world countries, and I see that a lot of NGOs are involved, a lot of non-governmental organizations are actually involved. You need to work with the NGOs, plus you need to work with the physicians. That other physicians already, the patients have a different kind of physicians, right? They have primary care physicians, so you have to work with other providers. You have a constant pressure, high pressure environment, and low resources. It is a challenge itself. How do you do that? The whole process. How do you accommodate the whole thing?
Well, the good news is that once you set up locations and provide supplies, it becomes the same kind of camaraderie that you have in your everyday world. Once you make people feel safe and you put them in an environment that's familiar and you give them their regular job, that's one of the keys is, don't ask the OBGYN to do emergency medicine in a disaster unless you have no emergency medicine. Have emergency medicine do that. Have family practice do the family practice. Let the OB do the OB. You'll make the family practice and the ER guy happy. Don't ask the surgeon to be doing internal medicine ICU rounds. Let him do the surgeries. Let her do the surgeries. It's same with rehabilitative medicine. Get them in there taking care of those who are other enabled, who have physical challenges. Don't ask them to be doing pediatrics unless it's pediatric disability patients. You want to get people as much as possible in the realm where they're comfortable, and you want to create the safe environment. My job as a disaster medicine person is twofold. One, I'm an ER doctor. So I'm going to be in that red tent in triage, or I'm going to be in triage, or I'm going to be out in the field working a field response or a field hospital or a field clinic situation. But I'm also, because I'm disaster medicine, I'm going to be interfacing with local government. I'm going to be interfacing with local emergency management. I will be liaisoning between emergency management locally and federal assets to make certain that if a resource is needed, that it's available. Or I may be at a hospital liaisoning between the hospital and various levels of emergency management to be sure that that hospital continues to have supplies, because it's the hospital and its team, the local team, who are taking care of their community, doing their work. And my job as a disaster medicine doctor is to make sure that the job of medicine is possible, to make certain that supplies, people, communications, as you pointed out, Robert, all of these components are there. Obviously, also, we're going to coordinate with the other emergency support functions. We want to get the power back on at the hospital, or get the fuel truck there to keep that generator running. One or the other, or preferably both. It's about resource management. I heard it likened once to being almost as if you were managing your household budget. Where are you going to spend your dollars to pay all the bills? Because the disaster is the bill you have to pay. And the dollars are the resources. Some of those resources are people. Some of those resources are volunteers. You mentioned volunteer organizations. There's actually a national coordinating group called Volunteer Organizations Active in Disasters, or NVOAD. They help coordinate disaster volunteer groups. Great group. I'm not trying to plug anybody in particular, but one great example are the Southern Baptist Chainsaw Team. Now, these are all retirees with chainsaws. That should scare you in medicine. because you have old people on anticoagulants running around with chainsaws in a disaster. But they are expert with these chainsaws. And what do? They clear the roads so that the linesmen and the EMS and law enforcement can get through the disaster zone and actually help people. They're not there to do rescues. They're not there to feed people. They're not making sandwiches. They come in with chainsaws and chainsaw fuel and their own support staff and their own lunch. And they cut until they're tired, and then they leave.
Talking
And
about,
they can clear all the roads or get it down to the point where the road department can now clear the roads. And that's critical.
yes,
Everybody
absolutely.
has a role.
It's
We have
interesting.
we
isn't
have
it?
the Cajun Navy. One of my favorite names in all of disaster is the Cajun Navy. They were founded after Katrina. It was a bunch of guys originally with John boats in Louisiana going out to just get people out of their homes to an evacuation site. They didn't do rescue. They did minimal first aid. Their job was they pick you up and they transported you. And if you didn't want to get in the boat, that's fine. I'll go to the next house and get them out of the boat. Well, now they're a national organization, everybody local, and it's people who own boats who want to help. But in order to be part of a disaster, you have to have a certain level of training. You have to have a badge to be recognized by law enforcement, so we know you're a good guy, not a looter. And as part of the Cajun Navy, these volunteers show up, and again, they pick you up. So you're in Wisconsin, the Cajun Navy in Wisconsin. You have a flood. Here they are with their boats. Could be a canoe. They pick you up. They take you to the closest evacuation point, and they go back and get another person until they run out of gas or daylight, or they hit their exhaustion point. And this is another great opportunity to work with local and regional volunteers. And I could name thousands of groups like this, each one very specialized, doing a component, because how does society work as a whole? We in medicine are a small part of society. As a society, society works as a whole with individual groups doing their job, doing it well, and leaving the other jobs to the other people. Where we get in trouble in medicine is always where we try to do more than we're trained to do. So they make it possible for you and I in a disaster to take care of our community, or for me as a disaster medicine person to come in and take care of the community.
These are the non-governmental organizations, volunteer organizations. They're providing services without getting paid. So now let us talk about the dollars, and then how do they get paid? These are hospitals, these are disaster zones, hospitals, or any other organizations need to get paid. How do they get paid?
Well, for the provider, the rules are the same. You document. Yeah, hopefully your EMR is still up and running, but sometimes you have to document on paper. You code, you record your E-codes for external events, and you send it down to your billing department, or to, if you're in a private practice, to your billing service. At your billing service now has to coordinate with the emergency management office, because during a declaration, during an active federal disaster response, the coordination of payment is often through the Joint Operations Center for the disaster. So your bill routes a different way. Now, because we do electronic billing now rather than the old days where we put it in the mail, the electronics takes care of a lot of that for us. But the bill then goes into the insurance clearing system for however that is set up in your state, and those are regional by state. And the emergency declaration will cover a percentage of those costs. So those in some states, those are reimbursed through the insurance company. So the insurance company pays the bill and the Fed reimburses the insurance company. In other states, the Fed pays the bill directly. So the hospital submits its bill through its normal electronic system. That bill routes around, and ends up being paid out of federal dollars for the federal response. It's a little different if you're a federal disaster partner, although that program is being changed. In that situation, you have a special billing arrangement to bill directly for disaster management, but those hospitals know who they are and how to do that. And it's a little different if you are out in the field responding not a federal or state employee. In those circumstances, you have to have had you have to be a contractor with the emergency management, either locally or at the federal level. Those are all arrangements you've made in advance. And again, how you will bill for those services you've been given those instructions in advance of your deployment.
Are you billing the FEMA or anybody, certain particular organizations? They're dedicated for the providing the financial things. What are the structure to that, Dr. Ramirez?
Well, you're not sending the bill directly to FEMA yourself. Okay, you're completing the usual insurance reimbursement electronic form. It's going through the usual submission process. It's being routed at the state or federal level, or at the insurance company level, to the appropriate office to get that reimbursement. The difference is whose bank account is ultimately paying the bill. Because, as I said, there may be an insurance intermediary who covers the bill up front, but then it comes later. It's not unlike when you have a health related issue and an automobile accident on the same admission to the hospital. You don't submit two different billing forms. You submit one, and the two insurance companies negotiate out who is paying for what portion of that hospitalization. So the patient has a car accident and then has a heart attack. The heart attack was not causally related to the auto accident. Therefore, the health insurance is going to pay for the heart attack and the bypass surgery, but the auto is going to pay for the trauma and some portion of the hospitalization. So they work it out between them. So that's worked out at the other end. The key here is more to know that you are part of a disaster, that you were part of that response, and that you had all the preparations. There are also certain requirements that you have to have in place in order to be part of the system, to be part of that response. For healthcare providers, those are courses. They're available on our institute website by link. They are available directly from the federal government. They're courses that are paid for by your tax dollars, but they're called ICS, or Incident Command 100, 200, 700, and 800. If you don't have those, you don't get to come and play at the party, and you don't get to bill for being at the party. But yeah, so it's a little bit of online learning. Those are the courses that teach you to coordinate with the management system that's going to be in place during the disaster response.
So, if I understand you correctly, you build the insurance company first, and they in turn get paid by the federal government, the federal agencies. They pay them, and then that is the structure. That is. Am I right in the direction? Yeah.
In most cases, yes. Not in all cases, because every disaster budget is a little different.
So you started.
You bill it the regular way. I'm sorry, Sheila. Go ahead.
Sheila, you have any questions? Go ahead and ask a
Yeah,
question.
I was just going to say, this is such a complex topic, and we could go on. Maybe we'll have to bring you back. But is the High Alert Institute there to also provide training? It sounded like some online courses, but if I were to say, I wish there were doubles and triplets of you so that we could do more and more in terms of preparedness. Is that what the High Alert Institute does?
Well, the High Alert Institute has 4 divisions. And yes, one of them is our Disaster Readiness Education Division. Originally, it was founded after 9/11 in 2002. And for its first decade, it gave live in-person training programs, either directly from the Institute or through various contracts with universities or state health systems, all under federal dollars. We trained 5 or 6 states. Some were just a little bit shy of 20% of the hospitals that existed at that time. We were in at some point during that decade to do training. We trained over 20,000 healthcare providers, and we did that in person. And we did triage training. We did disaster behavioral health training, which we haven't spoken about yet. We did drill and exercise training, logistical training, and disaster preparedness and disaster readiness education. We also, at that same time, started a website right around 2007, where we curated links to external training programs that could be done online, or and back then, of course, online was download and watch a slideshow, but where you could train online and then get a certificate of completion from a university or from FEMA directly to show that you had completed these various courses. The reason we curated the data and the links was so that people in healthcare knew exactly what they needed to take. Because if you go to the FEMA EMI website, which is a great site, a lot of fantastic training, but it covers all 18 emergency support functions. So as a healthcare provider, which ones are for you? And which ones are for you as a physician, as opposed to a nurse manager, as opposed to a paramedic? Complicate that. In 2009, we started doing pandemic preparedness training around the country. So now we added a ton of additional education. Health and Human Services, CDC, all started developing their own training programs and training presentations, TEKS and other universities. All of this created on the federal dime with the promise that it would be free going forward to participants. Now, today, there are over 10,000 federally paid for training opportunities, exceeding real quick math, exceeding 90,000 hours of available training. Nobody could complete it all. And it's on sites like train.gov and National Child Traumatic Stress Network and SAMHSA and CDC and believe it or not, USDA. Some of it's at Homeland Security. So
CDC also involved, right? CDC also involved.
All CDC also, yes. So and CDC has 4 different websites with training. So when you go to get this training, and Health and Human Services has training, but they have it on a site that's at train.gov, not at HHS. So when you try to find something that you need, not only do you have to find it among 10,000 other items, but you have to find the website where it's located. So we curate lists.
Right.
And that's why our organization, as part of its mission, curates lists. Currently, our website is highlighting things in the One Health, One Nature, animal health, and animal wellness area, because that industry and veterinarians currently have a mandate that is unfunded for education, and the education is available for them for free, but it's hard to find. So we've curated a list of 28 of 10,000 courses, and we're blessed. We have many volunteers who are subject matter experts who have gone through and looked at or had to take these courses for their own education and professional advancement. And so they've come back and told us, these courses are good. These courses are best for a veterinarian. These courses are best for an animal shelter, for a zoo, for an aquarium, for a hospital ER, for the intensivist, for the surgeon, for the oncologist. Remember, people with cancer still need treatment after a disaster. And some hospitals don't reopen for 2 or 3 weeks. Some infusion centers for a month or more. Well, that's not acceptable delay in cancer care. So folks have to be connected into the disaster system in order to provide the ongoing care. Dialysis is another great example. You can't wait a week for your dialysis center to reopen. So emergency dialysis has to be provided. And that can't be done in the hospital. There just aren't enough machines in hospitals to do all of the outpatient dialysis for a community. So
fascinating. Fascinating, Dr. Ramirez.
All these aspects that we support through disaster medicine for the local community, and that's the key. Communities recover when they can take care of themselves again. So the key is to get them to the point where they're providing the care for their own neighbors, their own staff, their own relatives. And that's when a community begins the recovery process.
Absolutely impressive, Dr. Ramirez. When I get back, I'll ask you about the High Alert Institute's function, what kind of work you do. So after I'm presenting my topic there, the topic is actually very related to you. It is a low resource settings. How do you present the low resource settings, the healthcare in other countries? We can watch together, all of us. Just a minute. Yes. So this is the 2 doctors, silent heroes of the medicine. I'm going to talk about these two gentlemen. Actually, in my village, this is my village. It's a name of the village is Palakoderu. There is when I was growing up, there was no electricity, no running water, and then is a very limited resources we have. I believe me or not, in the 60s and 70s, in fact, we have a bullock cart like a Oregon Trail wagons that we used to go for a transportation. You believe me or not, that is still at the time agriculture-based economy that I lived in a small village. Though we have Russian tractors, that's what we used to get. I'm going to explain to you how the healthcare resources are provided in these kind of villages. Deaths of tropical diseases are very common. Typhoid and bacterial and parasitic infections, malaria, cholera is very, very common. And eosinophilic lung, tropical diseases, these are all these usual suspects in the deaths. So then in those countries, that is believe me or not, there is another deaths due to cobra bites. We used to have a lot of cobras, in my village. So we have a lot of poisonous snakes that, in Dr. Ramirez lives in Florida, probably there's a lot of other snakes there. So the poisonous snakes, the cobra bites are very common. A lot of people used to die. And then suicides are not that common, but they used to take a pesticides and die. I entirely witnessed one suicide during my high school time. But there's a cobra bites. We don't have any anti-poisonous. They are not available. So a lot of people used to die with the cobra bites. Pregnant women, there's a lot of this delivered by midwives. Midwives deliver most of the birth, labor. So healthcare in rural villages is a bicycle doctor. There's a walking doctor. There's a foot doctors. In China they used to call, but in India they used to go in a bike and they provide the care directly into the house. They go directly to the house of the patient, home of the patient, and they provide the care. There's a bag, you see, usual bag is there. My father, Dr. Subbarao Anamraju, is my father, who is a teacher and doctor. He is himself provided, he is a bicycle doctor. And then I used to hang around with him sometimes. I used to go with him. He used to take me to these patients' houses. He was originally a teacher, but he's self-taught. There's no other doctors in that village. So he's a self-taught, and he got an externship from my other grandfather. And then, he passes some exams, and he became a doctor and provided care provider in that small village. He's the only one who knows how to speak English in that area. So he used to read a lot of unrelenting. He was always a vivid reader of medical magazines. That is, healthcare in rural villages is a true point of care. Actually, that is coming back in the United States. Healthcare delivery is a point of care, is a diagnosis, and then treatment and the prognosis are all done at the same place. As a disaster medicine, Dr. Ramirez is talking about, that's what exactly that we do, diagnosis and the treatment and the prognosis you have to do at the same time with much more tough conditions. So this is the how do they get paid? Reimbursements, you're talking about federal billing, the federal insurance. There is no federal insurance there during that time, 60s and 70s. So the as you know, in 50s also in the United States, they give vegetables, eggs, and chicken as usual, and then no insurance. They used to give us my father used to get a gold or silver during the twice a year. We used to do special celebration, religious function. They used to come and give money or gold or silver, vegetables, all these kind of things. That's a very common thing. It's a concierge medicine in a style. We already invented a concierge medicine. So the silent hero is my teacher. My father and mother really provided the care for those 2,000 people in the village. There is no absolutely, the healthcare is non-existent. My father is a savior in that sense, that my mother really put up with those things, and she really supported my father to provide this extraordinary care for the villagers. But I'm going to talk about another doctor. Is both of them same name? Dr. Subbarao is not my father, but he's the same name as my father. Is unknown famous man. I tell you, he's a very unknown famous man. Whether you know it or not, he discovered the first chemotherapy drug, and first broad spectrum antibiotic, first strip test, first topical drug. all his medicines are a World Health Organization essential list, and nobody knows about him. Can you believe that? I tell you about that. His name is Dr. Yellaprakada Subbarao. He was born in 12th of January 1895. Then he was a Somarama is in my village. We are cluster villages. My village is a small village. We're connected with a small town called Bhimavaram. That's Somarama. That's what the name of the town is called. It's a Lord Shiva's 5 temples. He's one of the houses of the Lord Shiva. That's why it is called Somarama. So, but he failed high school 3 times, got married at the age of 15, the gentleman who invented all those things, and then his father-in-law got worried about him and then sent him to the medical college in the Madras, Chennai. Now it's called Chennai. He went to Tamil Nadu medical school. He graduated. At the time, India was under the British rule. The Queen Elizabeth was our ruler, So he graduated from medical school and he started teaching in Ayurveda college. Then all of a sudden he got interested in applying. He applied for Harvard Medical School. In 1923, they rejected him in the beginning because he said that he doesn't have the Ayurveda is a traditional medicine we don't do. But he said that no, I took the actual physiology and anatomy, all those things. I took it because I took a traditional medicine classes under the British rule. So he got the admission in the Harvard in 1923. So he came to Harvard. Then he was a biochemist. He did a tropical medicine degree. He became a doctor of tropical medicine, and then he got the Ph.D. from the biochemistry, and he became a faculty member in the Harvard. But his papers were stolen. He was discriminated, and he denied a tenure. This doctor. So eventually he got tired of it. He's a very failed 3 times. The man who failed 3 times became a Ph.D. and a faculty member in Harvard. Can you believe that? It's his dedication. And he denied he was discriminated. He's actually supervisor hidden his papers. It is listed in the Wikipedia, in fact. So he he got the job as a director. He was nominated. He's so brilliant. So they took him as a literally laboratories in Pearl River, New York. He was appointed as a director of the lab. So they were a small boutique pharmaceutical company. They hired him as a director. It's the first invention. It's a first-paid invention, strip color test. He's the one inventor of the strip color test. The calcium is the biggest mineral in the body. The second one is the phosphorus. People with the diabetes and alcoholics, they are deficient in the phosphorus. So then you can measure he invented the strip test first. And after that, the second invention he did, heterozoan tablets, is a eosinophilic lung, a lot of diseases there. So he invented he came up with the formula heterozoan tablets. These are now is a part of the World Health Organization essential drug list. Antiparasitic drugs, antithylaminics. That's what the drug. In fact, it has saved millions of people. That heterozoan tablets. Then the mother of all his inventions came in. In 1940s, there was a cancer. There is a child cancer, leukemia. It's a very prevalent. They don't know it is. They cannot do surgery because blood is perfused all over the body. You cannot do surgery, or you have to have a targeted medicine. So he came up with the folic acid and analog to the folic acid. It's called methotrexate. He was the inventor of he discovered the methotrexate. He gave it to the Sydney Farber. So he really is the inventor of the first chemotherapy drug, methotrexate. So he is already well known during this time. But besides that, the fourth invention is antibiotic, first broad spectrum antibiotic drug, automycin. He did in the literally laboratories that he got some grass from the wild grass from the Missouri, and then he got this. He discovered the antibiotic, first broad spectrum antibiotic. So after that, he went to the 3 Southerners. The Benjamin Dugard from Alabama is a plantation owner's son, and then Dr. Subbarao is from southern India, and then Dr. Louis Wright is from LaGrange, Georgia, where I'm from, Atlanta, actually. So he is a slave of a son owner. They're all together. They did not, when they found out the ivermectin, no big laboratories or no universities gave them clinical trials. So Dr. Louis Wright is already well known, very well respected surgeon. He came from the Air Force, and then Harlem Hospital, as chief of Harlem Hospital, he gave the opportunity to Dr. Subbarao to do the clinical trials. It was a grand success. It's a ringing endorsement. It's approved by FDA. That saved millions of lives. That one. Lederle Labs eventually became a Pfizer. Now it is owned by Pfizer. So he deserves 4 Nobel Prizes. He got none. He was overlooked by Nobel Prizes. He's a well noted about this thing. Is unfortunately he was not he was discriminated, but he's a well-known man. Delapragada Subarao died in 1948. The same year, Mahatma Gandhi died. He won the freedom for India, but he won the freedom for the diseases, freedom from the diseases for entire world. So the New York Times, they wrote down, the New York Herald Tribune at the time, they didn't recognize him. One of the most eminent medical minds of the century. That's what they said about him. The Jewish advocate said that because he lived longer. That's what they said about him. They had a bust in the Pfizer labs, and now they had a bust. So people like my father and him, and my father is at the local level, but he did the international. On a personal note, both have the same name, came from the same town, and both helped people. My father had nothing. He provided care for people who had nothing in a small southern village in India. My father, Subbarao, helped the villagers, and other Dr. Subbarao helped the world. People come and go, but the nobility of these people who serve silently really make the better tomorrow for all of us, for the humanity. Thank you for listening. And then this is the shirt. I will talk about it. So see that I'll bring it back. I'll bring back Dr. Ramirez, and he knows that just see that. What do you think of Dr. Ramirez? People like you who are the award winners. There are a lot of that is the nobility of the physicians. People like you and those kind of people who need
Very relevant to what you talked about. Yes, Dr. Ramirez, really thank you for everything that you've done in disaster medicine to help the many out there. So yeah, kudos. It was a great presentation that blended well with what Dr. Ramirez has done with his career. Thank you.
Well, thank you. It's not about the awards as your father. My father was a traveling afoot doctor in the Philippines. So it's not. It's about the service. It's not about the awards. I didn't even know that I had been the recipient of the award until I was asked to come to somebody else to a dinner to install an officer who I knew in an organization. I had no idea that I had been nominated or was up for that particular award. It's of course very gratifying, very humbling to be so recognized. But there are thousands of not just physicians, but first responders, average people who have come out in their communities, in every community during this pandemic, in every country, every continent, every state, every municipality worldwide, who did some part of their part, whether they stocked grocery shelves or they cleaned up. The most important people in the hospital aren't the physicians. I'm sorry, my colleagues, but that's just a truth. It's the people who clean up after us, who ensure that we have a clean, safe, as close to sterile or at least aseptic environment as possible to be the healthcare provider. That we don't also have to push the broom, empty the trash, take out the biohazardous material. It's those, clean the toilets. When my mother was a nurse, part of their job was still to clean the toilets. And that was in a major US city. Yeah, okay, back in the 50s, but still, that was part of their job. And they don't have to do that anymore because we have custodial people, folks who remove garbage, people who patrol the streets, the people who ensure that our communications work. And a lot of people make fun of actors and entertainers, but during COVID, they provided an important social and behavioral health function. A recently deceased actor, I was unaware, had been doing daily videos on TikTok that were just humorous for no reason, other than he wasn't in production and he was hoping to make people's days better. And that's part of what we do, again, during a disaster, during an emergency, to do the part that we can to restore society. That's what it's really about.
Dr. Ramirez, what do you do with High Alert Institute? What is the function of the High Alert Institute?
Well, our institute is founded to provide disaster readiness education, response and recovery capabilities to underserved and unserved communities, as well as those who have an unfunded mandate for training or education. We ended up with, we currently have 4 divisions in the institute. I mentioned our disaster readiness education division. We also have a division of environmental stewardship and social drivers of health. The interconnection between the environment that we live in, the locality where people are, where they live, work, play, learn, and worship, and the impact on their health. These are things that are outside of the individual's control. They are very often within the community's control, but these are important factors. One of them during COVID that came to light was that people of color were 8 times more likely to die of COVID-19 if they ended up in the ICU in 2020. Well, it turned out that number did not deal with socioeconomics. It dealt with the environmental driver of health of where they lived. The majority of those patients who were in that cohort, where that number, that 8-fold, that's an 800% increase in death rate, was identified, were primarily city dwellers. And as people of color, although they were socioeconomically disadvantaged compared to their non-people of color comrades, they also lived in public housing. Well, we were concerned about airborne disease in public housing, so we opened all the ventilation. These folks also, one of the other social goods of public housing is we put public housing on bus routes. Buses run on diesel fuel. Diesel fuel emits carbon black, micro black carbon. Micro black carbon in the lungs when you have a coronavirus and the insipated secretions that comes with it turns almost to concrete. It doesn't drain. So the problem was not that these were people of color. It would have happened to anybody living in those same buildings that were then opened up for ventilation because we were trying to do a social good, decrease the viral load inside the indoor air. But we brought in the outdoor air pollution that then filled their lungs with carbon black, that then thickened their secretions to the point where they became insipated. They developed pneumonia and consolidations and died on the ventilator of COVID-19. But they died of...
What does your company do for that kind of situations? What do you do, Dr.?
Well, right now we are working we are working with some private companies and some not-for-profits in environmental remediation of forever chemicals. We are starting some work now with working groups with other not-for-profits that are looking at social drivers and environmental determinants of health data, because we never would have discovered the carbon black issue had people not already been concerned about indoor and outdoor air quality in those communities. So that data, when correlated to the health outcome of a massive increase in death rates, resulted in the discovery that air pollution and exposure to air pollution is a risk factor for COVID death. Okay. There are 414 themed areas identified by the WHO for environmental and social drivers and determinants of health. And those couldn't be correlated against thousands of diagnosis codes regionally. That's being done in some universities, but most of that data hasn't been correlated yet. And that may identify new areas where we might be able to improve health at a community or a national, even global level by addressing those factors. WHO in 2015 identified noise pollution as a factor in diabetes, of all things. A 14% increase in diabetes if you are exposed to a constant 55 decibels or greater 24 hours a day. That's amazing.
I'd imagine it's a stressor, right?
Man created lead poisoning. Lead is also playing a very important role. Now they found out the 100 times more than our bones and our bodies contain, 100 times more than when 1940s and 1920s when compared to that.
Oh, absolutely. Forever chemicals are in 98% of all pooled blood specimens from all blood banks worldwide in both the industrialized world and the developing world, and those chemicals didn't even exist 79 years ago. And we have gotten it to the point where it's in all of our food chain worldwide. It's in all of our blood supplies worldwide, which means it's in all of our bodies worldwide. And what's the health impact of that? We know some of them, solid organ tumors, pelvic organ tumors, reproductive tumors, cardiovascular disease. Believe it or not, an increase in cholesterol levels comes from causally related to forever chemical exposure. Diabetes again comes up, neuroendocrine disorders, and behavioral health disorders. So and this is a chemical factor, a chemical environmental determinant of health. We have no idea at this moment what will happen when and if we can remove that from our environment and our food chain. And is that damage to this generation of people and our children permanent, and it'll be our grandchildren or our great-grandchildren who will benefit from our removing those chemicals from manufacture? Or is it something that if we remove it now, does it save you and me too? Right. We don't know, because it's been around for so long that literally all of our medical literature that we count on, the last 50 years of medical literature, are all in the shadow of those chemicals.
You're addressing a lot of infrastructure problems that is a big challenge. But
developed countries, right?
Is at beginning stages. Anything you want to say, Sheila? You want to say anything?
One quick question. I love this discussion. And again, thank you so much for sharing this with us tonight. I am wondering about cyber attacks and cybersecurity and disaster medicine. Is there a role for disaster medicine for protecting hospitals from data breaches? And, we have so much that runs now on the internet, and there were some threats years ago. How do you reconcile that?
Well, Sheila, you're talking about this subsection of disaster medicine that intersects with One Health security, which is also part of the One Health, One Nature model. We've all seen the television shows and the TV police dramas where a hacker takes a hospital hostage by putting ransomware on their computer. Give us $20 million, and or we won't release the blood work. And that's real. That has happened. That happens on a monthly, if not weekly, basis somewhere in the United States or EU, where a bad actor is what we refer to them as. A bad actor comes in and does something to the computer system. But there are also more insidious events that can be done. Hacks that change lab results have occurred. And then, of course, the problem with computers is garbage in, garbage out. Right. But many, many, many people view the computer data as the final arbiter of truth. So it's garbage in, gospel out. Yes. And it has happened where doctors, despite their, when you interview them, they say, I knew there was something wrong. It didn't make any sense. And yet they treated the number despite the patient in front of them. And then it turned out that the number was either erroneous due to software error, or it was erroneous due to a malicious actor involved in the situation. And these attacks are occurring more and more. So yes, there are whole divisions of national governments worldwide that are involved in healthcare cybersecurity. The colleges and the associations for healthcare information management, both here in the United States and globally, a big portion of their operations deal with setting standards for cybersecurity. But the reality is that the individual provider, the one thing that you cannot hack, despite the colloquial use of the term hack, is the human brain, at least not yet.
Yes.
And
we have a couple of minutes
Benjamin
left.
Franklin once said, common sense is not common. But
Right.
for providers, common sense has to be common.
That's my
you
motto.
look at a patient and you're told the glucose is 1,000. My first response as an ER doctor is repeat the glucose and do an AccuCheck for me. If I don't see it on 2 results, we're not giving that person. We're not going to give that person 50 units of insulin IV. That's
Great
just not
advice.
happening.
Your website is highalertinstitute.com, right, Dr. Ramirez?
HighAlertInstitute.org. We're a not-for-profit.
highalertinstitute.org. Dr. Ramirez, it's truly an honor to talk with you, sir. It is an educational inspiration. You're truly an inspiration, not only for just the other doctors, the inspiration to the entire humanity. Thank you so much. Thank you.
Thank you so much for
Sheila,
having
for
us.
joining with me.
Thank
you
you
all.
very much. Appreciate it. Have a great evening.
Bye-bye.
Bye-bye.
The MedBricks webcast is focused on bringing distinguished Indian